and welcome, Dr. Ghofrany.
Hi, how are you?
I'm great. And so we are going to talk all things vagina today, my
Can't
favorite
wait.
topic.
My favorite word to say.
I never thought, even 10 years ago, I would be saying the word vagina in public.
Oh my
And
gosh, yeah.
yeah, it's my favorite word.
I mean, last night,
So
by the way, just to interject really quick, last night I was in an event that had nothing to do with vaginas or vulvas, but for the fact that the audience were women. And yet I still managed to find a way to throw it in because I feel like we should
awesome.
talk about it more, right?
Awesome.
Yeah, yeah.
Well, and so I'll use the word vagina, but I really always mean, all the vulva, the labia.
Yes, all of
But I
it.
like to clarify that because sometimes it upsets clinicians. I know you wouldn't be, but
No.
yeah. So tell me a little bit about your passion and energy for this space. So I see you in different places and you're always on, the energy, the enthusiasm.
Thank
What
you.
keeps you going?
I think what most people think is that I love being a doctor and that I must have always wanted to be a doctor and that I must love women's health. And interestingly, those are kind of side effects of what I really love most. I always joke that what I love most is engaging with people, all people, really. And I want it to be a 360-degree, give and take. I want to learn from them and I want to be able to
Mhm.
talk and have it be back and forth. And I fell into medicine, which is a longer story, so it worked out that I managed to be able to all at once honor women, take care of women. I get to be a surgeon, I get to be their primary care doctor, and I get to do what I love, which is engaging with people.
Mhm.
And so that's what keeps me going. I mean, truly, there are times where I'm like depleted and exhausted and don't have the energy to do anything. But if someone comes into my field and wants to engage, I perk up again. And so it's just worked out that that happens to be a trait that makes for good doctoring, right? Like I
Mhm.
don't think that I'm a good doctor
Absolutely.
because I'm brilliant. I think I'm a good doctor because I actually enjoy people. And I think there's a lot of clinicians who are brilliant, but they
Mhm.
don't enjoy people. And
Yeah.
then that gets in their way. And so I
Yeah.
think, yeah, that's where the women's health part comes into it because as it turns out, I actually really love taking care of women much more than men because I understand them better.
Well, and it's not just being liking people, it's actually being authentically curious about them and wanting to
Yes.
learn. Like you said, I want to learn from them. And so, how do you bottle that up in medical training and spread that kind of approach? I
Yeah.
don't know if it's possible.
Well, you have to talk fast and you have to be compulsive. And unfortunately, at some point, something gives. As you and
Yeah.
I have talked about, like part of it,
Yeah.
what gave in my world is that I work a little bit less in the office because it was impossible to do it 30 times a day as I did for 23 years and continue and actually be healthy. So it's too bad, really.
And this time of life for women, it is such a shift, can be such a shift in identity. And what are some of the common things that you're hearing or seeing in your clinic, that women are saying about themselves at this time?
Well, interestingly, in my actual practice where I'm face to face with patients in person, I'm dealing with obstetrics, though there is an overlap. First of all, because so many women now getting pregnant are actually also perimenopausal.
Hmm.
They're in
Hmm.
their mid to late 30s, early 40s, late 40s, sometimes early 50s. They're perimenopausal
Yeah.
and pregnant or postpartum. And then I see patients virtually in my telehealth practice. And then I see women just at events in life. And I think the common themes, first and foremost, are women seem to be surprised when I am very open about everything I've been through. And whether it's my weight issues, my miscarriages, my cancer, marital issues, whatever, they're surprised, but also they all tend to say the same thing. Oh my gosh, it was so refreshing that
Hmm.
you were transparent. And
Hmm.
I'm consistently surprised by it because I keep thinking, why aren't we all transparent? It just
I
feels
know.
easier,
I
right?
know.
And so, one common theme that I think is emerging in midlife right now, and maybe because of social media, so I will give it a check in the favor of what's good about social media because we know there's so much ill about it. I think one thing that is emerging in this midlife, outside of the obvious, where we'll talk about hormones and everything, is this desire to be more authentic and open and not have to put on a facade of life is good. I have the perfect marriage, perfect life, perfect family. And I love that. I think that that is really going to be one of the things that's going to help women and people in general with their physical health, their emotional health, their family life,
Hmm.
all of it, right? Because if you can't be authentic and open, then it permeates everything. You can't be open about your hot flashes, your night sweats, the fact that you don't want to have sex, the fact that you feel heavier, the fact that your husband snoring makes you want to gouge your eyes out, right? You can't be honest about that. If you can't be open and honest, then you can't talk transparently about the troubles you're having with being, taking care of elderly parents while taking care of teenage children, or the fact that you're exhausted by being a mother, or the fact that you don't know what to do in your career, right? So the lack of transparency, unfortunately, has pervaded every part of our life, medicine, everything, right?
100%.
So I think that, to me, is the most prevalent emerging trend that I see outside of the obvious. We're finally talking about menopause, right? Everyone keeps saying menopause is having a moment, which I, by the way, hate that term.
Yeah.
Because it shouldn't be a moment.
No,
we should
it's not a
always have been
moment.
talking about it. I actually feel like I've always talked about it.
Yeah.
And a moment implies that it's like a fleeting thing. This should be now and forever. We should have pre-menopause discussions versus post-menopause discussions as far as how much we talk about it.
Well, and I think, certainly when I was younger, trying to live up to that, perfect persona of the professional woman that was an executive, had kids, was racing, had it all, and didn't let anybody know anything. And then, with perimenopause, just kind of hit this crashing wall of and being free and just saying whatever. And, I noticed that women really gravitated towards it. And so the second you sort of go there, you can almost see a physical release in them.
Absolutely.
And then they get a bit more comfortable and a bit more comfortable. And then it's like an awesome sharing opportunity. And, when I have my daughter is 19. And so I openly talk about all things sexual and in front of her friends too. And, they act a bit mortified, but then I hear, that they call me the vagina mom, and they actually kind of like it. But I think that generation is going to be really different out of the gate. They seem to be a bit freer in who they are as women.
They're less embarrassed.
Exciting.
Yeah. I love that they are less embarrassed, and hopefully they will recognize the value of sharing with your friends. Because to your point, I agree. I always say that if I'm in my office and I have a patient who is in her late 30s, early 40s, and before she even tells me anything, I say, let me guess, are you feeling any variety of? And, I go through the laundry list of symptoms. I can feel their energy and their physique change, just like you mentioned. And I think they think, oh my God. And I always joke, I think you think that I'm mentioning something unique. And here's the good news. None of this is unique. Thank God. You don't want to be unique when it comes to your medical care. It doesn't mean we should dismiss it. But I think that overlap, as I always call it, the overlapping Venn diagram of when all of us open up as women, we recognize that we all share so many things that why wouldn't we open? I mean, it just, again, to me, it feels so much easier. Yeah. But it's the one thing that I think is going to save our humanity in our communities is being more honest.
Yeah. Well, and especially with perimenopause, I think the awareness is increasing, that it happens before your period ends and the whole gamut of symptoms. But I don't think we're quite there yet where, a woman would start to hit into her 30s and sort of realize that things are off. And so by openly talking and openly sharing, it almost creates that early awareness for perimenopause, which I think is so important. And, I get so disheartened that women have to go through that period of time where they're beating themselves up. Why am I not motivated? What's wrong with me? What's happening? Instead of, because I think that education, even before you get any treatment of, this is perimenopause, is freeing. It's a so freeing sense,
Yeah. Well, the hard part though, don't you think is, first of all, I think you and I are very much in these silos where we, I joke isn't everyone talking about perimenopause? But the honest answer is and then I talk about it in these educated group sessions where, I'm doing public speaking thinking they're going to be bored. They've heard me say it. And these women are like, oh my gosh, what? So there's millions of women not getting the information. The second part that I think is hard is it's you don't know what you don't know. There are still cohorts of women who, when I dip my toe and talk about perimenopause, you can tell they're kind of I'm not there yet. Mm-hmm. And the answer is, no, you are. You just don't know it. And you don't want to hear it yet because you can't receive it yet. So I'm a very big fan of preemptive knowledge and kind of telling them just enough so that then once they're able to receive it, in a year or 2 years, 3 years, or when they have their first hot flash, it'll have sat there in the back of their mind and they'll be like, I heard it before. It's not as shocking as I thought. Right. Yeah. But I think it's still a lot of work for us to do to try to educate.
So much work. And whenever I hear a woman say, oh, I was lucky, I didn't have anything. I'm trying to figure out the right message, to your point, that will tweak in their brain. That they're almost in a bit of a more dangerous spot because, the chronic issues that are potentially eroding and causing risk factors for your heart, your cardiometabolic system, your bones,
Your
it's like a
brain.
silent risk that
Yeah.
you're walking around thinking, oh, I wasn't impacted by menopause.
Right.
It just, I'm trying to find the right messaging
I
where it's
know.
not like, what? It's
Well,
just
I
a
think,
subtle cue to say
yes.
like, hmm.
Oh, I know. It's such a good point because you also don't want to be, I don't want to be patronizing and be like, oh, honey,
Yeah.
you don't know that you are. But interestingly, I think a lot of these patients, a lot of these women will say, I feel fine during perimenopause or I'm postmenopausal and I didn't have any symptoms because they only think of the hot flashes and night sweats.
True.
And if you say to them, oh, that's great, meaning so like your sleep is completely fine, they'll often be like, well, no, I mean, my sleep sucks, but isn't that normal? Or like, oh, of course I wake up at 3 a.m, then I can't fall back asleep. And they don't necessarily recognize that that is probably, first of all, I think that part of waking up at 3 a.m, besides just our rhythm and everything, is that you probably had a hot flash or a night sweat. You just didn't know it. And so that probably should be bundled into vasomotor symptoms, right? Especially when we talk about treatment, because that alone, even though it's not a sanctioned reason to treat with hormone replacement, meaning sleep disturbance alone isn't a reason according to our guidelines.
Yeah.
You and I know it helps sleep, and sleep is going to help all of the things that you discussed. So
yeah.
So I think a lot of them just don't know. And, then there's always the suffering question. I always say, like, how much suffering is enough suffering when we talk about like, the guidelines say if you have debilitating hot flashes, if you have bothersome hot flashes, which implies to us you should tolerate a certain amount. But how much should we tolerate? I just think it's such an
and
unfair...
I think it's just a discourse for women. Like we just tolerate, we just put up with it.
Right. Because we're encouraged to.
Yeah. And like, that's a very interesting point because I appreciate guidelines. And in a past life, I worked on clinical practice guidelines and was like a big advocate. And now that I sort of step back with a different lens of, because there's not enough random control trials, but logically there's some good evidence, why does a doctor get to absolutely decide yay or nay for a person who does have the ability to make decisions for themselves? And while I think guidelines are super, super important to guide, I sometimes worry a bit when I'm hearing certain doctors battle it out with each other, which is a whole other conversation, but that, the confusion for women and almost the erosion of their confidence to be able to say like, I'm not sleeping, I'm not doing this, let's fix it. And the ability to take hormone therapy for that.
Yeah, I think it's so multifactorial. I would say, and again, I know that you and I've talked about Canada versus America, and I don't understand the Canadian system as well. I think that the problem in
Nobody
America,
does. It's okay.
Nobody does. I know. I've said a lot that I don't want to blame the doctors who don't have time in their 15-minute visits because of the insurance model in America. Because I think that's unfair to them. They have a lot to cover in 15 minutes, right?
Yeah.
And I also don't want to blame them because, as many people know who are listening, gynecologists and generally and doctors in general do not get education in menopause during residency. So it means on our own time and our own dime, we have to keep learning about everything. And it's not just gynecology, right? We have to learn about everything in gynecology, everything in obstetrics. So I don't want to blame the doctors for not having the time or the knowledge. No. I do blame the doctors who don't have the time, don't have the knowledge, and then don't recognize that they don't have the time or knowledge and therefore refer out. And so instead of doing that, what they tend to do is kind of revert back to like, here are the guidelines, the Menopause Society guidelines say hot flashes, night sweats, or osteoporosis prevention. You don't fall into those guidelines, therefore. And the extra layer is that we don't even look for osteoporosis until 65, right? Oh, the extra layer is that we have malpractice that no one really wants to talk openly about. But the fact is, for me to have I skirt those guidelines in that I'll talk very openly to my patients. And I do think shared decision making, as much as it's an annoying term, is really valuable, but it requires you to be able to educate your patient, you to be able to have time to educate your patient, you to be able to say, listen, here are the reasons I can, like, that are sanctioned for me to give you hormone replacement. Sleep is technically not one of them, but you and I are adults. Let's talk about the risks and the benefits and the studies that we know. And you can come to the conclusion that you want to use it, and I'm going to prescribe it for you. But the underbelly of all this is also malpractice. So let's say that patient uses the hormones and then develops breast cancer, even though you and I know it wasn't from the hormones, but there's still enough past data that she could still sue her doctor. And so to not address all of that in the system feels unfair because not only is it vilifying clinicians, it's furthering the rift between clinicians and patients, right? Because now patients are kind of learning this rhetoric of like, it's just the doctor's gaslighting. When listen, are there shitty doctors and patriarchal medicine? Of course. But there's also the system that has created this. And if we don't address that, then I feel like it's just going to do a disservice to the doctors who are staying in the insurance model, who I really value, because it's so hard to be in that model, you know?
Yeah.
So I think, unfortunately, it's so multifaceted and not
it really is
addressed. And it's not going to be fixed in our lifetime. Sadly, I will say that.
No, I hear you. I agree with that. But I do think we can empower women to figure out, am I with the right provider? Yes, and so I think you've raised something in a way that I haven't sort of heard as recommendations to patients. And so obviously the first one is like, does the provider know what they're talking about? But the second is, I think you have a sense if they sort of shut you down, that perhaps they're uncomfortable in the fact that they don't know what to say. Yes. And probing in that a little bit in terms of like, you know, what your education or in a positive way, that might get you to a spot where you understand that the physician, because we're all human, the physician doesn't really want to admit that they don't know enough about it. And rather than refer you out, they're just going to sort of get you off the topic. Yeah.
I would say for I would personally say, as much as I like to defend the clinicians, anytime a patient is with a clinician and feels shut down, I think it's probably just an energetic mismatch, right? Either that doctor or PA or nurse practitioner sucks, or they're insecure, or maybe they are not shutting you down, but somehow they're not communicating in the way that you need. And so it's not easy to just switch doctors because, again, in America, it's so hard to find doctors who take insurance and all that. But I think our task as a doctor is to be able to say yes or no, or I don't know, in a way that is delivered by giving the patient the reasons why we're saying yes or no, or I don't know, right? Yeah. And I think not every doctor is adept at it. Not every doctor has time, all those reasons. So I think you can certainly probe and kind of try to figure out why, but the honest answer is if they're not willing to either tell you why they think you shouldn't be on hormones in a very appropriate way that resonates with you, or refer you out, then you probably should move on. But I think a lot of people don't even know that they should. You know, some people are in flagrant mistrust of doctors. Other people trust doctors so much that well, my doctor said no, therefore I can't do it. And it's, you know, that's like a hard conundrum, because I don't want to kind of encourage people not to trust doctors, because we do a lot of training. Great. Right? Yeah. And some of the times the reasons we say no are right? But I also don't want anyone to blindly trust doctors. And that's right. That nuance is really challenging, because it requires women, and this is one of the hardest things that I don't think we talk about enough. It requires women to have some level of confidence in themselves, not blind trust because like I've done the research and I've read on the internet and I saw this influencer say something, because that is not confidence in yourself. That is putting trust, maybe not in your doctor, but in someone else. But to be able to have the confidence to kind of discern and say, is this someone who I think is really listening to me? And it makes sense when she says I shouldn't be on it because of XYZ, or is she, you know, just blindly saying no, and I need to trust that I should find someone else who can describe it, not someone who will just prescribe, but someone who will explain why. Yeah.
Well, and I think for women, that's such a journey to trust your spidey senses, whether it's a doctor or anything, to say, you know what, that's interesting, that opinion's interesting, that whatever's interesting, but it doesn't work for me. Yeah. And, you know, I think it's a journey for women to get there. And, you know, just reflecting back, just yesterday, I had a situation with a commercial partner that went sideways. And I was like, why didn't I trust myself during all of that? Like I knew, you know, and so I just think it's the same in every context for women to really get to the spot where they can stand in their own space and be like, you know what, that doesn't work for me. And, you know, find another doctor or find another.
Well, and isn't it because of our intuition, right? Like I think women, I mean, people, but women certainly have intuition, but I do think they are systematically taught in this last 20 years of the explosion of social media and guides and things like that. We're systematically taught, don't listen to your intuition. There is a book on that. There is an expert on that, right? So, and when it comes to like having a baby or even menopause, right? Like there's these people, you have to listen to them. Now, of course, when it comes to certain medical facts, you're going to learn from people. But unfortunately, many of the people in the space, whether it's wellness, medicine, politics, they say things in such a black and white that they make everyone believe that it is the fact, when in fact we know that Nothing has
Nothing.
an absolute truth, right? There are multiple truths. But because women are taught not to listen to their intuition, they then follow what people say.
Mm-hmm.
They think that their intuition is telling them like, oh, this is the right way. When in fact, they're really just, instead of listening to their doctor, they're saying like, my intuition told me the doctor's wrong. I should do this. But it just means they're listening to the other person instead of their doctor, not their own intuition.
Right.
And I think, again,
100%.
it's such a nuanced thing. I don't even know how we could teach it to people because it requires a level of generally feeling confident with knowing what you don't know as a person and being able to kind of sniff out what feels authentic or not. And that's not an easy, there's no task there that we can do easily.
Well, and also I think with the speed of information and the chaos of life, finding someone to say, oh, they said that, it almost lets you take out any accountability you have or any cognitive effort, right? So it's a break to be like, oh yeah, I'm going to do what they are saying, versus like putting the cognitive effort in to reflect and think like, is that right? And maybe seek out other opinions. I think we do seek that out because we just can't keep up with the pace of everything.
Right.
Right.
Well, and now there's, when you and I were growing up, I think I'm older than you, but ish, there tended to be just a couple of opinions. And so the good news was it was easier. I will never forget this great anecdote. A patient of mine who I had taken care of when she was about 20 years old, she had her first baby. We had babies at the same time. So our children are now 21. And, I was like an educated physician. She was like a young, not as educated 20-year-old, surprisingly having a baby. Flash forward now, I don't know how many years ago, but 14 years later, she is a social worker. She's intentionally having a pregnancy. She's educated.
Oh, wow.
And she said, oh my gosh, I've never felt less secure. She said, I cannot believe that when I was 20 and I knew nothing and I had basically no one but like my mother, I actually felt like I was a pretty good mom. And now all of a sudden, as an educated person with all the resources at age, she was like 34 to 35 at that point, having her second child, she felt insecure. And I so understood it. I said, yes, it's because now you're seeking all the resources because that's what we're telling people to do. Do your research.
Yeah.
And so I'm speaking out of both sides of my mouth. You have to not all at once blindly trust one person. But the problem is now it's become, now I have 10,000 people that I'm supposed to trust. And they're all saying different things with conviction. So I'm now confused what the right answer is. And so what I always say to my young moms is when you hear all these different answers, don't let it confuse you. Let it inform you that there's no one right answer. There's multiple ways to do this. You might change your ways over time and you need to have a little bit of your own intuition and trust. Yeah. But I thought that was so fascinating and so telling that like with this age of information, it's only increasing our anxiety to a degree.
Oh, 100%. And especially as it relates to healthcare and wellness, because it's always the nuance of, but if, but if you have this risk factor or, if you start at this point, like so if somebody blatantly comes out and the message in that 2-second soundbite is, this is great. And somebody else has done a ton of research and is like, well, but no, it's not that great because of, they're going to come out and say it's not great. And so the devil's always in the details, right? And so what they're both saying is actually correct, but neither's putting out the information because it's also quick to give the nuance, context of what's behind it all. And so I think that's the danger as well. So for the blessings of this social media and information age, it does behoove you to decide like, when am I going to dive deep? And the good news is there's so many great resources out there to get synthesis of peer-reviewed journals and interpret them. Like back in the day where I had to find the journal and go down the library walkway and read it or photocopy it, it's come quite a way. But yeah, it's tough. It's tough for sure. And as we just sort of talked about the context for guidelines, the American Urological Association did come out with some new guidelines for GSM. And I haven't had a chance to really sit in the quiet with them. I'm so excited that I'm talking with you. Yeah. What would you share about some of the exciting things that they've kind of shed light on or kind of come about bolder about for women?
Yeah. Well, let me first lead by saying, of course, again, I am an OBGYN. We tend to claim or feel that we are the purveyors of women's health and reproductive health. And the truth is there's a little bit of a rift and animosity between gynecologists and urologists. Like there's a lot of gynecologists who kind of feel like, look, who are those urologists infringing on, or acting as if they know. But here's the truth. Urologists in many ways, I'm really impressed. They have taken the mantle of sexual health for women and certainly pelvic floor health. So I give them credit because they have
Yeah.
paved the way. In particular, a couple of them. I mean, Rachel Rubin has done some really amazing work with vaginal estrogen and really popularizing it and making it clear how safe it is. As you and I know, we'll say it for the audience, vaginal estrogen, meaning local estrogen in the form of a cream, a tablet, a vaginal ring, a suppository, really works for genitourinary syndrome of menopause, which is what we used to call vaginal atrophy. I kind of liked the old term better, but that's okay. And it really is what people will say is dry vagina, though I always say it's not dry, it's inelastic because you can still lubricate on your own sometimes.
Yeah.
And sometimes you have discharge, but it's not elastic. So it hurts when someone has friction against it, whether it's sex or a vibrator or even a bike seat rubbing against or your underwear. And so not only can it cause painful sex, but it can cause urinary tract infections. So the AUA, the American Urological Association guidelines are very meticulous, very clear about the preponderance of evidence that tells us that vaginal and vulvar estrogen are safe, that we have tons of data showing that the estrogen does not get absorbed systemically. They have all of the studies showing that you don't have an elevated estrogen level. And therefore, almost every single person with a vagina and vulva, save for a very, very, very small group of people, shouldn't use it, meaning all of us can use it, including women who have had stroke, heart attack, blood clot, and estrogen receptor positive breast cancer. And that's revolutionary because not only does it mean you can have more comfortable sex, but almost more importantly, it means you don't have to suffer from recurrent urinary tract infections. Or when women are in nursing homes, we know that a huge amount of morbidity and money is spent on urinary tract infections. That could be alleviated. So it's actually, it sounds so simplistic, but it's miraculous. So I think it's great to know that. I'm glad that they've spearheaded it. And then, you know, I've said to my patients for the 26 years I've been practicing, because I've always been a vocal proponent of vaginal estrogen, not only for women who are perimenopausal or postmenopausal, but as you know, women who are lactating. So right after pregnancy, if you're lactating, you will have a very inelastic vagina. And if you're on often any kind of hormonal contraception, but in particular combined hormone contraception, it will, unfortunately, even though it's giving you estrogen, it will even out your hormones in a way that the receptors in your vagina and vulva become very inelastic. So we see a lot of young women on birth control pills, and they have the same genitourinary syndrome of combined hormone contraception. They have those symptoms. They all are behooved by vaginal and vulvar estrogen. And so we really need to get the word out because it's, I can't say it's nothing, but it's like, could be anywhere as low as $30 for a tube, which can last a couple months. It is very safe, but it has to be used regularly. It has to be used forever if you're postmenopausal. And you have to ignore the current package insert, which says risk of stroke and heart attack and blood clot and breast cancer. That is wrong. Again, a lot of the urologists and many of us are trying to campaign to get that packaging removed by the FDA, but I don't think we're going anywhere with that for a while. So yeah, I'm thrilled they did it. Good for them. I love that they did it.
Well, and I think this is such a critical message. Even I don't love the term genitourinary syndrome of menopause because it almost sounds like it's a sort of point in time and it's fixable.
Right.
And so like I can just deal with it. But it really is, in my mind, a point in time where just not in the context of earlier years with birth control pill and those things, but in the context of perimenopause and menopause, it's really a time to say, like, you know, if you look at your facial skin, it's going to lose elasticity. It's going to go dry. Like, it's a part of aging. Like, these things are going to happen to your vaginal urinary systems. It's going to get dry. It's going to get less elastic. These things are going to happen to varying degrees at different paces, depending on who you are.
Right.
And so you put cream on your face. We spend so much cream on our face and these things for our face and our skin. And so the knowledge, like, keep that area healthy and use it preventatively. Like, I know it's a bit of a gray area and certain physicians don't like to sort of come out with it as a preventative thing. But I can't understand why it wouldn't be.
I know. Well, it is interesting. I think that I kind of try to keep reminding all of my people who listen that this can all at once be natural, because it is natural, right? It's natural and normal that our tissue will get less elastic with the lack of estrogen. But what is not natural is our longevity. We have outsmarted nature, right? Nature was like, you're going to go through menopause, you're going to dry up, all those things, but then you're going to be dead by, 50 something ish. So we have to accept that we have already gone against nature by living into our 80s and 90s. Wonderful. we've gone against nature by having phones and cars, right? So then how do we work against nature, but in a way that can still be safe and healthy? And absolutely, like vaginal estrogen to me is such a low lift that it should be over the counter and it should be available and discussed for everyone. And like I say to my patients, I do think it's probably wise to start it ahead of time, and it's a little bit hard to kind of convince people of that. So I also will say, if they're like, well, do I really have to start it now? The answer is, listen, if you don't want to start now, it's okay. And then just wait. If you start having even a hint of like, oh, that felt a little funny, don't wait till it gets bad. Then immediately start.
Yeah.
What I think we don't want is for women to go so far past where they're like grinning and like bearing it if they decide to have sex, or they're getting recurrent urinary tract infections and they're just being treated with antibiotics. Because then, can the estrogen still work? Yes. But it's just like, I always joke with my neck. If I could have like stopped my neck from being gaggly before, it would have been better. Or if I could have like halted it the minute it started, right? Once it gets super wrinkly, it's just going to be harder to get it to be more elastic. So I think you've made great points. I do think that is, doctors are reluctant to preemptively start people on it. And I think, again, part of it is the conundrum of just a conversation about vaginal estrogen could take a good, if done well, 10 to 15 minutes. And that's not even a comprehensive. That's just like, hey, it might not be covered. Hey, this is the package insert. This is how you use it. These are the things that might happen. Right? So how do we do that at an annual exam where you only have 15 minutes to talk about everything? Right?
Yeah. And for women who, are like the grin and bear it, which are a lot of it, they're sort of jumping on a trampoline and peeing or dribbling a little bit when they have to go pee. They're drier than they were before, but it's not so dry. How do we raise awareness that like, that's not actually healthy? Like you don't have to live like that.
I know. Well, that's why,
How?
I know. Well, that's why I keep joking, like how much suffering is too much suffering? Like, because women do say that all the time about everything, right? Whether it's pregnancy, periods, all of it. Like, how's your period? How bad is it? Well, it's not that bad. Okay. Well, tell me what is not that bad.
Yeah.
Oh, it's fine. I mean, I can handle it. Like, which I always joke, like, of course you can handle it. We can handle a lot. Yeah. Doesn't mean we should.
Need to.
Partially for the health benefits, like you said, and partially for like, even if there's no health detriment, why would you have to why would you be forced to tolerate something that we can safely fix? So I think, again, it's no easy answer because every woman is different. But what I would really urge women to not feel is that they have to have any level of discomfort, unless they really actively choose to. And even choosing to, I would argue, you probably only choose to withstand discomfort because of societal norms that are subtly taught to you. So I don't even know if any of us have enough free will to be able to say, well, I'm okay with it and I'm willfully choosing to suffer this much, because really we're choosing that level of suffering based on what we've been taught as women. Like that it's a badge of honor or whatever it is, right? So I would say any level of discomfort when you have sex, or if you're getting a UTI and you are peri or postmenopausal, please start vaginal estrogen, because it will be safer. Forget it'll make you feel better. It will be safer for you than anything else, because taking recurrent antibiotics is not good for our microbiome or for general resistance for our community. So there's a lot of reasons why we should be more vocal and aggressive about saying it's really important, not just for your benefit, not just for your comfort, but for your true health benefit.
Well, and I would beg every clinician not to ask a female patient, is it that bad, or how bad is it? Because the fact that they're saying it means it's bad.
Yes.
And in fact, probe more, because there's probably other things they think they could just live with.
Right.
Yeah.
Well, and the data that most patients will not bring up any of these things, any discomfort in their pelvic floor, whether it's, and then I see it with my own patients who I think, like, I've known them for decades and I'm so honest about everything open. Why would they not tell me? And yet women will come in and I'll say, so how's everything going? Like, are you okay having sex, or what's going on with urine? Are you dripping urine? And they're like, well, yeah, I guess so, but it's okay. And I'm like, wait, A, why is it okay? And B, why aren't you telling me this? Like, tell me it's okay. I'm not embarrassed by it. I think women also still, again, our generation and above, are embarrassed by a lot of these things, which is to me so deeply sad. Like, to be embarrassed about something that almost all of us are going to experience in some way or another is sad, right? We should not be embarrassed by the things that are common.
Well, and I do think there's still obviously reinforcement in the media. And in particular, there's some products that are important that we have on the market, like things that can absorb urine. but they almost reinforce that it's a normal part of aging, right? Versus like you if treated, if you're on top of things, in theory, you should never ever need that
Right.
device
Well,
to.
well, how do we, the hard part with urinary incontinence, right, is obviously we know that it's mostly going to be caused by childbirth, vaginal childbirth. Not
Yeah.
exclusively. People with C-sections, people who have had babies can have it, but almost, the vast majority of people with urinary incontinence because of vaginal childbirth. So it is a very common side effect of it. And I think it's good to normalize it, quote unquote, so it's not embarrassing.
Yeah.
But how do we do that without being like, well, it's normal and common, therefore
Yeah.
suck it up, buttercup, right? Like, so we have to have like a very comprehensive way of saying, yes, it's natural. Yes, it's common. Yes, it can happen to many women. Yes, there are products to help you, but also we can try to prevent it by doing this. Also, we can try to treat it. It's all
Yeah.
of it has to be told. And how do you
Yeah.
do that in sound bites? And how do you do that in a doctor's office in
Yeah.
quick visits, right?
Yeah.
So that's why I think these platforms are great, because you can help educate women so that they go to the doctor with a little bit more knowledge, so that 15 minutes can be really impactful for them,
Yeah.
right?
Yeah. Yeah. And so I know we said that we live in this kind of little silo. But what do you see as positive shifts that are happening in the space of, women's menopause care? Do you think that we're moving the mark?
Oh, absolutely. Well, okay. Objectively, the data, there's like anywhere from 3 to 4% of women are on hormone replacement in our country. So objectively, no, but how quickly is that data updated?
Right.
I don't know. Subjectively, I absolutely think we're making a mark, right? We're talking about it. More doctors are learning about it. More doctors are treating it. More doctors are aware of it. More clinicians in general understand that it is a multi-organ issue, right? It's not just hot flashes, night sweats. Now we know that our joints, our skin, our brain, all of it. So I do think we're moving the needle. I think sadly, like anything, there is a bit of a trend of a cash grab that you and I know and we see in this space, where there are a lot of companies that are just capitalizing on women's insecurities and on women's symptoms and on women's discontent with the medical model, right? Allopathic medicine has not served women in many ways. And so these companies are capitalizing on women's distrust. So they're creating like the proprietary blend of some herbal supplement that claims that it's going to fix everything, right? So we know that the supplement market is trillions and trillions of dollars, like so much more than the pharmaceutical market. And then the problem is the pharmaceutical market is flawed in many ways. So I think we've made strides. And yet I think there's also complexities and problems like anything else.
Yeah, 100%.
Yeah.
Well, I thank you so much for your time today. I am thrilled that you made the time for this conversation. I really, really enjoyed it. I think it's very practical and helpful for women. And I look forward to hopefully being able to chat with you again.
Yeah. Thank you. It was great. I always enjoyed talking. Bye.